So Christina is the registered nurse at the Rapid Access Addictions Medicine Clinic in Thunder Bay, Ontario. She was raised in a rural town of Southern Ontario before moving to Ottawa to obtain her Bachelor of Arts in Biology at Carleton University. On its completion, she embarked on a backpacking trip across India for several months, which opened her eyes to the challenges and resiliency of those less fortunate, and served as the inspiration to get into the field of nursing. She moved to Thunder Bay to obtain her Bachelor of Science in Nursing at Lakehead University and stayed to start her career and a family, falling in love with the beauty of Northwestern Ontario. Her nursing career began in acute care oncology, but years later, she moved into community care as a hepatitis C treatment nurse, followed by outpatient mental health nursing. When the RAAM clinic opened in Thunder Bay, she felt it was the perfect fit both for herself and the needs of the community. She is a member of the newly launched Medify Provincial Advisory Committee, where she hopes to bring a strong voice for Northwestern Ontario to the discussion. Welcome, Christina.
Thank you so much, Leslie. Hi, everybody. Thank you so much for joining the session today. I'm admittedly very nervous, but I'm going to do my best here with this new sort of platform. It's really great. I think that we can all come together, even though we're not there in person. So I'm going to do my best to share some of the strategies and things that we're using here at our clinics, and which many of you may already be using some of these things. But as Leslie said, I'm hoping to have this be very interactive. So I'm in Thunder Bay. Not everything in Thunder Bay is necessarily going to work for where you are, though I did try to draw on some broad examples. So please use the chat. Let's be interactive, because you have other resources and ideas and things that you may be using. So I want you to share those with everybody that's here participating today as best as we can. Okay, so some of the goals, I just wanted to talk about specific barriers that are preventing our clients from engaging in traditional services, essentially. And then considering the unique role that RAAM clinics can fill, like why are we here? What is it that we're doing that's working? Yeah, because I feel that in Thunder Bay specifically, it was something that was much needed. And so I just kind of want to get into why that is. I wanted to learn and have you also share approaches that may be useful to overcoming those barriers, specifically that are preventing people from engaging in care, and then discussing some external supports and partners that we can all draw on. And again, I'll try to make that a little bit broader so that it applies to everybody here. Okay, so this is the Thunder Bay team. So it's a dream team. I I have to admit we are really, really fortunate to have all of these partners at the table here. We have mental health and addiction services, counseling services, Indigenous services. We're especially now based largely in the Community Health Center, which is my employer. And I'll talk more about what community health centers can do, and specific roles that they can fill and support for you as well, whether or not you're based in one or affiliated with one. And then a peer support organization, and that's been really key for some of our work in keeping people engaged. So as I say, it's a dream team in the formal partnership sense of the word, but it's also a dream team here in person. I work with a fantastic team. They're all super dedicated, empathetic individuals who always go that extra mile. And so some of the strategies and things that I'm going to bring forward, these are just my strategies and resources. A lot of them have been used by the Community Health Center here for a long time. And we've been using them. Specifically, one of my mentors here and co-workers, Tanis Fletcher Stackhouse, she's the heart and soul of a lot of the programs here, but a lot of these ideas also come from her experience of working. And just to talk a little bit about Thunder Bay, not always in the news for the best of reasons. We do have some challenges. I think all places do. Specifically, though, we do deal with a lot of issues with gangs, crime, racism, all sorts of things that seem to come up. It's not, I wouldn't like to say that actually represents Thunder Bay. These are things that you may hear about more so in the news, but there are specific challenges. And here where I work in the Norwest Community Health Center, we're in the east end of the city. There seems to be, a bigger disparity, and there's more poverty, more crime. We're located above the only consumption and treatment center in the city, and so just trying to do a lot of the work around harm reduction and stuff. And that's what community health centers do, is kind of trying to even out the playing field and work with people who are dealing with a lot of these socioeconomic challenges. And then for our clinic, I'll just also briefly say we have 3 clinics. Well, the third is soon to open, which will be on Fort William First Nation in the city at the Delico Family Health Team. We are working right now out of Norwest Community Health Center during COVID, but before that and going back to it after COVID, we are also located in the Balmoral Withdrawal Management Center, or the Detox. And that's been also a huge asset, being able to link people to people when they're trying to withdraw from substances and make changes. And there we are, right, to kind of help them pick up the pieces and direct them. So anyway, so that's a little bit about Thunder Bay. And yeah, just like I say, wonderful team that I work with. So I'm drawing on the inequities and the social determinants of health. Specifically, we're talking about barriers to care, right? So when you speak about the core determinants of health, we're talking about, like, that's a broader category. They're all interrelated factors. This probably brings a lot of people back to school, but genetics, our behavior, environmental and physical influences, medical care, and then the social factors. So having something change in one of those categories can have a cascading effect in the rest of things. Like, one example I think of is somebody who's possibly single parent family or low income. Maybe they also don't have access to medical benefits. So they're already dealing with disadvantages there. Now, that's going to lead to food insecurities. So now people are dealing with food insecurity, experiencing stress, right? How am I going to feed my family? What's that going to look like? And so dealing with stress, now we start to see those other things coming in: depression, anxiety. We know that people are predisposed for that when they're dealing with all these other issues. And so stress, anxiety, depression, and then that leads to maladaptive coping. Could be drugs and alcohol, right? So when those things start to come up, then we're also going to see things like problems attending work, which in turn can lead to job loss, right? So when people are struggling in one area, it does tend to have an effect on the other areas in their life. So we're going to try these polling questions here. It's encouraged to be interactive. So do you routinely inquire into the current social and economic situations for new clients attending your clinic? So this is when they're first coming in and you've never met them before. Are there certain things that you're going to ask that are going to draw out what's happening for them socially and economically? So I'll give you guys a minute to kind of weigh in on that. Oh, it's going to ask me to do it too. I'm going to see here if we can get these answers to come up. All right, great, thanks. So 41% of you are routinely doing that when people come into the clinic. So that's excellent. And we're going to talk a bit more moving forward about why that is such an important thing to do. Okay, so we were talking about the broader determinants of health, but the ones that most public health officials are going to be looking at are the social determinants of health. So this is what's considered to be, and this may not be, the list may change depending on where you look, but this is often what's considered to be social determinants of health. And so these are basically the socioeconomic conditions, right? Sorry, I'm just going to find my note here if I can. So yeah, essentially what I'm talking about here is like, these are the imbalances. And again, this is what is going to bring out the barriers to people that are accessing your clinic. Because these are the things that are going to affect health equity, right? Why is it that not everybody is able to access the same services? And what can we do is looking at all these different things and seeing how can we try to balance this out for folks as best as we can, or at least understand where they're coming from and why these challenges exist. So this is just me kind of spitballing here. This is a lot of the stuff that, you know, I think I feel is disproportionately seen, right? When we're having clients enter the clinic, it's not uncommon to see a lot of these factors coming up for people. So kind of coming from that perspective of understanding that there's always a lot more to the picture, right? When they're coming in. And these are things that are going to come out in my first assessment with them, that they're going to bring up, you know, whether they are coming from the prison system, if they have different challenges. Trauma often comes up in that first appointment. And sometimes it's the first time they've actually spoken out about what they've been experiencing. So it's a unique, I think it's a unique situation that we put people in here, that they feel that they can kind of come out. They're very vulnerable when they come in. They're looking for help. And so just trying to gauge some of the extra things that might be going on. Of course, this is not a totally inclusive list, and I apologize if I've omitted anything that you feel is you know, important. This is just some of the stuff that I commonly see. So we're going to try one of these questions again. So what percentage of the clients that you're seeing in your clinic do you feel are disproportionately burdened by inequities in the social determinants of health? I know we're all working in a lot of different sectors and a lot of, or not sectors, or working in a lot of different environments. Some people are working in hospitals. Some people are, you know, working within, like, say, a family health team. So it's gonna, I think it does affect some of the people that you're gonna see. So I'm just curious, kind of wanted to see what you guys are experiencing. Roughly about the same percentage. Just looking at everybody's. Yeah, 75 to 100% is a lot of you. So that's, yeah, that aligns with what we kind of see here. So then I just wanted to talk then about RAAM clinics. Essentially, what is it that we can do in our roles? How are we uniquely kind of crafted to deal with some of these disparities that we're seeing? And if, you know, and if they're not things that you're already doing, I'm hoping maybe there's one or two things that might come up that would inspire you. And again, I just want to remind people, you know, feel free to use that chat and just share ideas and things that you're thinking about. That's really important. I'm only one person. It's my experience. So when we talk about the strengths of RAAM clinics, you know, just I think even number one here, the no ID, transportation, income, housing, phone, like these are huge things, right? And if you don't have these, how are you expected to attend your appointments? You know, you can't make it there. You can't make it necessarily on time. Extra challenges with COVID. Our buses were only taking a certain amount of people, and then it would just be bus full and it moves on. Yeah, not having a phone, the money to pay for your medications, and ID, that's been a big one for a lot of our folks as well. And then there's going to be other experiences as to why people are coming to a RAAM clinic specifically and not accessing other things that are out there. They may have primary care, but their primary care is feeling reluctant. They're not sure about prescribing medications like this. I've listened to some radio programs that also had other people from RAAMs on. I believe it's on CBC, and talking, and people just coming on and not having an idea that there are services like this, and that there are medications that can support them with alcohol, all this sort of stuff, right? So RAAM clinic stepping in has been a huge opportunity for a lot of places. Trauma-informed care, this is the model we work from, because essentially people are coming, they don't have trust, right? They've had other previous bad experiences, or this is just, they're hypervigilant and they're not in a space necessarily to approach traditional care services, and you just don't get that same interaction. Like, I think of, just people showing up late, maybe something really terrible has just happened to them while your appointment's canceled because you were 10 minutes late, like all these sorts of things that happen. Clients with untreated, undiagnosed mental health, anxiety, social anxiety, that's a huge barrier. Having multiple substance abuse, you may be attending, say, a methadone clinic, but you're also using crack cocaine daily, alcohol abuse, like these sorts of things. Having multiples, they're not necessarily going to address those for you. And whereas RAAM clinics are going to look at the whole picture. People being in the early stages of contemplating their substance use, attendance issues, like I mentioned, whether that's being late or just not showing up at all. People can always pick up the phone and call here again, and we're just going to keep trying again, right? And then fear of stigma and judgment. A lot of that is more for like acute care services, and sometimes it's self-stigma. I don't know if that's a real term, but I do find that people are their own worst enemy. Sometimes when it comes to going places, they think that they're going to be judged, whether or not that's the true experience. And coming someplace like this, they feel that, this is our business, we know this, and so we're going to be more understanding. And then specifically with concurrent disorders, that mental health piece, we know that, the stats are out there, could be up to 70% of people that have a substance use issue are also dealing with mental health. And so that brings some other challenges and barriers. So just not having primary care, that means that you're not getting referred to a lot of the services here. You need to have somebody that's going to, this is just a consult. We need you to go back to your family doctor after, and we need them to be the one to refer you and be responsible for your care. And so if you don't have that, you are out of luck. And then diverted referral. So that's, like I've known services where it sees that you're on Suboxone or methadone, and now we're going to divert you to a different service. It doesn't matter maybe that you've been on methadone for 10, 15 years and you haven't touched opiates in that long. That still kind of just ends up causing these diversions. Traditional services, having that same approach, and this is my chicken or the egg here, that you see, to make some sense, some context around that. But this idea that you just need to stop your cocaine use. You just need to stop drinking, right? And then you're not going to have anxiety anymore. Or then I'll prescribe for your ADHD if you can just stop using cocaine. And just having that approach, but not having any supports available to help them make those transitions, it doesn't end up being very helpful. Anxiety definitely being a huge issue just for, showing up at a new place you've been referred to. That's really big for some people. Or you may have to attend a workshop to attend and learn about the services first. And that's going to be in a great big group of people, right? And so then they just don't show up, and we, don't have to think too hard as to why that might be. And unmanaged substance use, whether you're missing your appointments, you're not sober when you're showing up. People just say, they're not ready for this, or this isn't appropriate at this time. So I just, I'm not going to go into the whole Maslow's hierarchy of needs here, but essentially it's this idea that you need to have a strong base, right? Like if people aren't getting sleep, they're not getting food, they don't have a safe place to be, how are they expected to go on and achieve their goals, right? So we really need to look at the basics of how people are living so that we can help them to move forward. And actually, when I look at this, I think of a treatment center, right? Like this idea, you're going to go in, you're getting hot meals, you've got a safe place to be and a bed. Now you're feeling secure, you're in a group of people, you're forming friendships, you're feeling belonging, you're feeling respected, and so, I wonder if that's why some of these programs are so successful, is that they're kind of touching on all these different points. But, definitely we want to look at that base there. What's going on for people? What are their needs? So that we can expect them to kind of do well. And how can we support them with that? So polling question number 3. Are there any resources or policies that have been implemented at your clinic to eliminate potential barriers to attendance? And that could be a variety of things. These are just some examples, like bus tickets, food vouchers, email reminders. So it's a lot of different things, but different ways that you've kind of modified your care or how you approach your intake to address some of those barriers for our folks. Sorry, I was just reading some of the chat here that some people are struggling to see some of the slides. So hopefully you're getting some help with that. I know they will be posting all this stuff on the Medify site later. So, so if you did miss anything important, you can always go back there. Okay, and I missed the responses there, but it looked like I was in the lower percentages, about 30 something. A lot to look at here, 45%. Oh, no, that's a different question. I don't know if you can pull up number 3, Andrea, but I think it was roughly around 30% or so. If not, don't worry about it. We can just go back to it. Okay. So now we want to talk about resources and strategies. So, knowing that there's all these barriers in place, what are things that we can do? Oh, and I do feel we missed a slide in there, but that's okay. So we'll just go kind of issue by issue with some of the things that we're seeing, but housing, right? So number 1, when people are coming in, this is the sort of stuff that I'm going to ask about on intake, right? What is your living situation? You can ask that in a variety of different ways, but knowing that a lot of our folks are homeless, and that could be a new situation. It could be that their substance use has led to, like we say, this cascading effect of things, and it could be marriage breakdown, job loss, people just basically saying, we can't deal with this anymore. You're not welcome to stay here anymore. It's kind of disrupting the family if they're just staying with other secondary family members. So there's a lot of things that bring people here. And so we try to look at what can we do to support people with that. I know it's hard when you don't always have a lot of time. Some of our clinics are pretty fast paced and stuff, but I think it's really important to look at that. And if you don't have the time yourself, again, looking at those other support folks, your peer support, there's a lot of things, and we'll talk about some of those other partners and stuff later. But if you can, it's about advocacy as well. So that may just be me picking up the phone to call the detox center to see if there's a bed available for them. Those sort of soft transfers, right? People don't feel comfortable necessarily. It does help having someone from our background being there for them and speaking for them and saying, this is something that they need. It could be on a do not admit list somewhere, and that could be at any of the shelters, and calling and just kind of advocating for them and seeing if we can open up those services to them again. Had many successes with that. So, and there's a lot more going on now because of COVID too, with temporary accommodations and shelters and stuff. So if you're able to pick up the phone and call and try to facilitate a place for them to be. In Thunder Bay, it's 40 below in the winter. It's, that could be death for a lot of people. If you think about somebody who's intoxicated, and then they're going to go out on the street, maybe they're not going to be aware that, that they are so cold, go to sleep, and, they might not wake up, right? So this is life or death for a lot of people. So if you're able to do anything to help facilitate that, look into it. I also mentioned here, like victim services and anti-human trafficking programs. That's something we're going to see often as somebody that's in a situation that they're looking to get out of. Maybe they can't go home. Maybe they've escaped from a situation. And so trying to connect them with those services on site at the clinic could mean that they're going to be safe that night and have a place to sleep. Sorry. Okay, there we go. And then we kind of want to plan ahead, right? So if we know that this person is homeless, maybe we're going to set them up with detox or somewhere else to stay for now. But, are they planning to go to treatment? So let's get on that. We're, linking them with our counselors who are going to be able to do other assessments. Their gains are going to help with treatment applications. Sometimes lining up that whole process of, their stop date, getting them into detox and then treatment. There's before and after care centers. So sometimes you can really have a nice flow going for people. They can leave detox, go into before care residences. I think we are fortunate in Thunder Bay that we have a lot of these places set up and they're working really well together. But, thinking outside the box where you can, and certainly trying to plan ahead for folks if you're able to at all. Just helping with those applications, informing them of what services are out there, maybe referring them to other programs where they might be able to get like housing subsidies and things like that. Personal identification, that's something that's going to come up on that first visit as well. A lot of folks don't have a health card. And so what's going to happen when we're going to prescribe medications for them? They have no ID at pharmacy. And so things like setting up passwords, that's been a big help for us, just asking them to let us know something that's very familiar to them that they're not going to forget. Maybe they want to write down. We're going to put that same password into the prescription. And so when they arrive there, that is their ID. They're going to write it on a piece of paper for the pharmacist, and they're going to take our word for it, right? So that's never been an issue for us here in Thunder Bay. I hope that could be something that is also successful in other areas. And then connecting them with those other services. It could be community health centers like the one where I work. We have community health workers. Doesn't matter that you're not rostered in these areas. You can refer them to community health centers, to the community health workers who will go through like obtaining their birth certificate. That's often the first step, right? We need to get that birth certificate so we can apply for the health card. And this is going to change someone's situation, right? This isn't just about them getting their prescription with us today. This is going to mean all kinds of things and all kinds of possibilities for them. You need to have ID for so many things. So, and it could be, their status cards. So contacting their band offices to see about getting that replaced, or even getting status in the first place. Our consumption and treatment centers, and I think most of them are geared towards this now, can help with things like that, getting ID. You may have transitioning clients that need to have their I put name changes. I meant there are name changes as well, but also gender changes for health cards. And then you want to think about how to help them in the future if they're going to lose their ID again. So we always take photocopies and put them directly into the chart. At least the person is able to go and get their health card number or get a photocopy so that they can have something to show. But there are other places that can act as your mailing address. I don't know if Ontario works, or here's the Thunder Bay District Social Services Administration Board, where you're also connecting with housing and all those sorts of things in one place. But they'll often allow people to use them as a mailing address. We do that here at our community health center. And, talking to them about ID banks, safe housing of their ID. yeah, so there's lots of different ways that we try to assist them with that as well. And then talking about Ontario Works and ODSP, we're specifically thinking about things like income, but also medication coverage, right? So if you're on these programs, then you're going to have access to the Ontario Drug Benefit Plan. And so, you know, a lot of people, they may have just been kind of disconnected for, you know, 2-3 years. They're starting over essentially. And so they haven't been on OW and just trying to get that process going for them. And that might just be a call over there to book them an intake appointment. You know, some people may need more help with that. So that's referring them to other agencies that can support them to take them to the appointments. ODSP forms is something that we also do here. And that's and that's for, it could be the special diet and transportation forms. They're coming to your appointments. This is going to give them extra money on their check, but also giving them more income. It's a substantial difference between OW and ODSP, which is going to mean a better place to live, maybe a safer neighborhood, all kinds of stuff. So we do have, we formed a policy around that here. So that means, you know, it's not just going to be you show up at your first appointment and that's something, it's not even something we advertise. But if we're following people here, if we've seen them at least 3 times and we know this is a need for them, then we're going to help them with that. You can, again, be an advocate. So that might be calling housing. There may be arrears. So trying to address some of that stuff for them, advocating, you know, about, you know, maybe the situation that they're in that they don't understand. You know, our folks aren't always the best at representing themselves. They're just kind of scared to deal with authority when they kind of know they're in trouble, different issues like that. And so just that extra call can really go a long way. And then there's additional services through Ontario Works and ODSP as well. So it's good to just inform them about stuff like that. And that's like clothing allowances for job interviews or jobs, childcare services. So just letting them know that those things are out there so they can meet with their worker. So medication coverage, we talked about the ODB program, but it also might be Trillium. We do struggle, and I'm sure everybody's struggling out there sometimes with finding the ways to get access for folks to pay for their medications, because Trillium can often be restrictive if you're living in a household with your parents. So now we have to take their income into account. And the deductibles can be quite large in those situations and not necessarily advantageous. So, but looking at those different avenues, what's out there, and trying to get them linked with those. And that could be, you know, just printing out the Trillium applications, helping them fill out the applications. There are the CRA has an online search tool if people are arrears in their taxes, because you do need to be up to date on your taxes to apply for Trillium. And so, so you can go on there and look up, and it's everywhere, every area. There you're going to find a free tax clinic, and they can be in the multicultural societies. They're all over. And then status card applications. Again, this is going to get you on the NIHB coverage. And so again, we can pay for medications. And then we had to think outside the box. And so this isn't necessarily a resource that's going to be there for everybody. But we have been able to allocate a certain amount of funds for temporary medication coverage. And so that means that they can actually bill to our clinic. We have very specific conditions we're looking at in those situations that, you know, this person's applying for OW. We know they're going to have that coverage. But here they are now presenting and they need to be on, say, opiate replacement therapy or something to help with their, with reducing alcohol use. And so what can we do just while we're waiting for that to happen? And so it's a little bit of a sales process here. We got to kind of run through folks and say, you know, these are the factors and this is what's going on. But again, that advocacy piece has worked really well for us here. And so we have been able to do that in certain circumstances. We also have a medication cart here. And so, you know, just being able to provide a little bit of a medication so that somebody can try it and see if that's something that's beneficial for them while they try to line up other things like OW or getting other finances to pay for their meds. No phone. always a challenge. A lot of people have already, there's email consent. A lot of places will use that. But other ways that we try to get around not having a phone is to always have like set appointment times. So whether or not we can remind them, they know, they're going to come in every second Tuesday at 2:00. Especially during COVID, there's been free phone provisions that have come up. So we definitely jumped on that and we're able to get phones for some of our clients. But in the past, in other work I've done, it's been advocating to just pay for a basic phone, and the client has to manage the monthly costs of that. I've always had an open door policy pretty much, I think everywhere I've been ever since moving out of acute care. So if somebody's going to show up here because they don't have a phone, they didn't have a way to connect, maybe they missed their appointment, I'm still going to see them and we're going to figure something out. And specifically with COVID, right? That people are coming up, they don't have a phone. We're not accepting walk-ins at this time per se, but somebody comes up and mentions to the screener that they want to connect with us, or they're coming in through our consumption treatment center downstairs, they're going to contact us. I might run downstairs, meet whoever's at the door and try to get something booked for them or figure out what their needs are and direct them appropriately. So just try to think outside the box, right? And that can look like a lot of different things, involving their case managers, lots of different stuff. So transportation issues. Again, we're lucky to have these resources that we're able to provide bus tickets. So that's, bus ticket to get home, bus ticket to get back for your next appointment. Try to eliminate those barriers. It could be taxi vouchers, like somebody needs to go to, like whether it's emergency or we're trying to get them to the detox center. And we need to make sure that they're going to get there safely. We have our alternate locations. And so, pre-COVID, but within the detox center. It's also our counselors in the way that they're so adaptable and seeing people at their home offices as well. So if that's a better location for somebody, either because they're not uncomfortable about accessing services there and maybe at our other places, that they're willing to do that for them. We've also been doing the virtual phone appointments, as I'm sure a lot of people have, which opens up the door to a lot of things, and even being able to access different times for people to attend. Case managers, again, pre-COVID, but people giving them rides to appointments and stuff, or outreach, being able to bring things to them. And we also do flexible scheduling. So that means if you are late for your appointment or you're not able to come during our time, we do try to adapt things a little bit if we can to make sure that people are still able to see us. And food insecurity, again, Maslow's hierarchy of needs here. So we always are going to provide food at the clinic. The lovely Carrie Ann, who greets everybody here, and I see that she's on our session here. So hi, Carrie Ann. Always doing special touches and having little snacks and things out for people, because we know they're coming in hungry. And you might want to think about your hours. Is this going to bump into times that they have to attend for the hot meal of the day? That might be at 2-3 o'clock in the afternoon, right? And so just try to keep that in mind and scheduling around that. I've worked at places where there's been good food box draws. We have more recently been able to have emergency food packages here. And that's just a wonderful thing to be able to give just individual food packages, just like crackers, a can of soup, some basic stuff, or family packages that are a little bit larger. If you think of the saying, if you feed them, they will come. So it's more of a necessity, I feel, in this case than the idea of drawing people in. But just keeping that in mind, right? People are hungry when they're coming here. This may be the first thing that they've had to eat that day. When I was doing screening during COVID, we were always giving out food and drink at the door. Like I said, we're in a bit of a marginalized neighborhood. So a lot of people coming up just for a snack, something to drink. And then through the community health center, there's all kinds of things. They're also dropping off food packages and stuff. And sometimes you need to, if these aren't things that you're able to access, you don't have the resources, then it's sometimes writing out grants and proposals, right? Is there anybody who has the time to do that, to approach these different places that might be able to give you an allotment of funding that is able to pay for that? And attendance, again, open door policies, email reminders, just trying to have that flexibility. We sometimes will extend prescriptions if there's, if they've contacted us, they let us know what's going on. Maybe they're going to attend the following day and see me and do a urine drug screen. And at that point, I'm going to be able to release their next prescription. So just trying to, realize the challenges that really might cause them to not be here in the first place, right? And making allowances for that. One of our prescribers here uses your drug screen cards. And so that's just kind of a little bit of a condition there. But, if you're going to attend, you do your urine drug screen, you get your card. Now you're going to show that at pharmacy. That's written into the prescription that they need to show a urine drug screen card on the Wednesday, and then they're going to keep getting their medications. And then, you may have to instigate rebooking policies, but, we usually try to give people, about 3 chances of, it could be an hour-long appointment, right, that we're setting aside for them. And then we think, okay, well, let's maybe go to, next time you're going to have to come as a walk-in or something else, right? So, or schedule with a different provider. And gift cards can be a good contingency management strategy as well. If people are showing up, great, awesome, $5 Tim card, right? Because we know it was hard for you to get here. High-risk individuals. So these are other barriers, right? Dealing with human trafficking situations. Maybe they're suicidal. These are the tough ones, but they're the ones that you can't ignore, and you really do need to try to implement something for them if you can. So just assessing their safety, things like suicide, like safety planning, referring them to a crisis service is going to check in with them later. You might need to send them to the ER. And if you haven't heard about it, because I hadn't before I came to the RAAM clinic, but there are local situation tables. There's more than 64 of them, I believe, across Ontario. And this is your police and your community social sector agencies that meet together, and it's for emergent situations. So these are some of the folks we see, right? That we know with the way things are going that they may end up getting arrested, or because they're suicidal, it may be risk to somebody else, that you're going to put a referral through them. So find out about it at all if you can, to see who are the agencies that you can refer to that can bring these things forward, or working with the police. You don't have to have client consent necessarily in these cases. There are a lot of things that have been set up to deal with that confidentiality issue. It's only going to be people who are saying, yes, we're going to help in this situation. We have a bunch of agencies step up to say, yes, we're going to support this person. And then at that point, you're going to move to a separate group. And that's when you're going to discuss who it is specifically that you're talking about and plan interventions to support them. So it's an excellent thing. So with COVID, I'm not going to get into a lot with COVID, but they talk about this 4th wave, right? So I think we're in the throes of it already. We're seeing an increase in patients presenting with acute suicidal ideation. We know the other things, the economic fallout of everything that's happened, people being burnt out. So I'm managing these in ways like drugs and alcohol, traumas, just checking in with people that we haven't heard from in months, and the things that have been going on. So I think we're already in the throes of this. And that can be a little overwhelming, right? So, but just knowing that, I think there is more of this to come. So we're going to have an even more important role to play moving forward. So 2 back-to-back polling questions here. So have you found yourself in situations where you feel inadequately prepared or supported to deal with the crisis at hand? And I know for myself, I can definitely say yes. If you don't mind just answering that quickly. Okay, so about 36% of you. And then we're actually going to move right away into another question here as well. So final polling question. If you did answer yes to the last question, if you didn't, just put does not apply to me, but have you used any of these situations to advocate for change in practice or seek additional supports? So basically, recognizing that I really felt, like I wasn't prepared for that situation, and next time I'm going to be prepared, and actually did something about it. So just while I'm waiting for this to tally, okay, 34%, awesome, that's great. I'm just noticing the time here, so I'm going to try to zoom through here. But the reason I asked that is because I've been in that situation, and as I see a lot of us had. And so, just really feeling like, my team members were busy. They've always been somebody I can go to for support, where it was just kind of like, it's on me and, I'm it. So I got to figure this out, right? And so that has led for us to kind of readdress. We do team meetings. We actually do pre and post rounds every day. So those are the times to check in and say, okay, what could we have done differently, or what can we be thinking about in the future? So this is where we need to look outside of our teams as well, right? So we can't always be everything. And so who can you call on? And that could be, the jail, anybody who's been there also has a parole and probation officer, for the most part. And these are people who also can make referrals and help you out. So just knowing that, you don't have to be everything and do everything. If you know they're linked with these people, that could be OW office. It could be, that they're going down to the consumption and treatment center, just getting them connected to those people so that they can move on those things for you. And again, having that benefit of peer support has been amazing for us. Case managers, I've specifically brought people to the situation table to get them case management. But once I was there, I learned about other agencies that are out there. So if you learn about them, knowing that there are outreach case management services, there are other places that you can do direct referrals, and even clients can do self-referrals. So those are the people who are going to help to facilitate all those connections for them. So if you can link them to them, it's going to make your job easier. Community health centers, having all those additional supports, groups, things. I put the website there for the Alliance because there's over, I believe, like 70, where is that here? There's 72 community health centers in Ontario. So we're not alone in doing this sort of work. They're specifically mandated towards working to evening out the playing field, dealing with the inequities in health. I'd put bread and butter on my other slide, and that's essentially what this is for them too. This is, this is the work that they've been doing for a long time. So call on them. They might be a link to primary care and other support folks that are out there, outreach clinics, all kinds of stuff. I put ONWA here specifically as another resource to look at because, again, this is an Ontario-wide thing. They're in Ottawa, they're in Toronto, they're all over. They have support services for people in the justice system, families experiencing violence. And there are other services out there, Indigenous Friendship Center, check them out. That's also all over Ontario. Just wealth of services, and your multicultural centers. There are so many different places, March of Dimes, dealing with employment, disabilities. And I hope, throw up some other ideas up there if you have them. Our detox center, like I said, picking up the phone and calling, but we're also now setting aside time every day in our clinics so that there's a spot there for our counselors to connect with somebody that's at detox, since we don't have the benefit of being there anymore and we're not having our walk-ins. So thinking outside the box as to what you can be doing now to really connect with those services that where your clients are at. And there's lots of different things out there. And just my little quote here. Alone we could do so little, together we can do so much. And that's within your teams, but that's also, again, as a community, right? There's a load of resources out there. So whenever you can set aside a little bit of time, do some research, find out what else is out there, it's just going to make your job easier, so that you can be that person that's connecting them, because they're there, they're seeing you. So yeah, anything you can do, any of those soft transfers and things, that's going to go a long way to helping support our folks. All right, so thank you. Really appreciate everybody coming on today, and I'm hoping to read some of these chats later too to see some of the ideas that you had. And I would like it to open up to some questions if we've got a couple of minutes here.
Great. Thank you so much. Go ahead. Okay. I'm getting some feedback, and I don't know why.
Okay.
There was a flurry of conversation, Christina, around the phone issue. Yeah. And there were some comments that staff have been given phones in one of the areas. Staff was given phones and clients committed to text messaging.
Yeah.
The question was, or the comment was, this doesn't really address literacy.
No, you're right. So again, there's a lot of different things you can do, but I mentioned the multicultural centers. And so depending on what the situation is, if it's a language thing, they actually do language instruction at the intercultural and multicultural centers. So if it's a language barrier that's in place, that's one thing. And I can't think of the specific agency here in Thunder Bay, but when I used to do hepatitis C care, I had a client whose goal was that he wanted to get his driver's license. And so there are literacy services out there that you can refer them to as well. And so I'd try to link it with his appointments coming to see me, that afterwards he was going to go to there, and he was going to get some actual instruction around that. So it doesn't, that's looking at a longer picture, I suppose. It doesn't completely eliminate that barrier for people, but it's also just having that person, right? So your outreach folks that are able to connect with them and then come see us and let us know what's going on for them or that they want to connect. So just having that person to person sort of contact can help with that barrier as well. I don't think anything's perfect, right? But it's just trying to be creative and do what you can. Right?
Great. How do we advocate to have services such as detox or housing in place? There was one idea in a community that had bus tickets for people to go to other communities that actually have those services. Admittedly stated, it's not ideal.
Yeah. We've had people showing up in Thunder Bay specifically for detox services. So they're coming from our northern communities and rural communities. Mm-hmm. And it could be even that they're in another city, but because of the substance they're using, we've seen that with crystal meth, that they're not allowed to attend those treatment centers. And so, just trying to, again, advocate for them, calling over, seeing if there's beds available. We do struggle with bed availability, and I think a lot of places do. So more on the broader level, I think there's here, it's the Thunder Bay Drug Strategy is really working to try to go to our municipal leaders about funding to get other things. There's also, right now, people going into hotels because of COVID, our MAPS program. So that's the Managed Alcohol Program. And those are around in a lot of various cities, coming into the hotels and seeing people there, bringing them alcohol. If they're not in a ready state for detox yet, but they're still, trying to work up to something like that, at least they're being supported. But outside from that, we are thinking a lot outside the box again with home detox. We've been doing a lot more of that. COVID kind of pushed us into it, sure. Out of the comfort zone a bit. And so just making sure that they have support people that are there to watch them, to help them, knowing that there's a little bit of stability there, right? And it's a risk, but intense health teaching, getting those other supports, those backups, knowing they're going to go to ER or call over to detox. Or maybe planning around when they get a bed availability, keep calling every 2 hours, you get a bed, connect with us. When we were at the detox, we would see them there and do the detox orders so that they have everything in place, their Valium, their sleeping pill, everything, as soon as they go over there. So.
Okay, thank you. I think we have time for one more question. when it comes to communicating and continuity of care with other services or caseworkers or POs, how do you manage ROI's consent to disclose information?
So sorry, I'm say that again.
How do you manage consent to disclose information between, I guess, patient when it comes to communicating with community of care and or other services or caseworkers?
Well, we'll get them to sign an additional consent that, like, we just kind of have an extra line for that. So if they want their case manager or their family member or anybody else involved, that they're specifically giving us that consent, but also with COVID, verbal consent and documenting that. They may be in the room. Yesterday, I had a gentleman here and I called while he was in the room so that he was able to give consent for the jail to fax over all his medical records from there, his medication records. So yeah, you often are going to have to involve the patient. The only situation where we haven't is that situation table, but there are specific conditions in place for that.
Okay. One more. Given all the strategies, what happens when clients get refused health services by physician because they are unable to wear a mask during COVID? They can't even go to emergency care, but where can we refer or send such clients to get the help that they need?
That's tricky. Like, I mean, we have our isolation room here for when people screen positive. We have our PPE and all that sort of stuff in place, but it is the recommendation. I can't say that it's been a huge issue for us. If somebody needs to pull down their mask a little bit, we know that we're wearing the appropriate gear if we need to put them in the isolation room so that it's appropriately vented, so that we can do that. Because there we can also set them up with OTN or other technologies and phone and that sort of stuff. So maybe they're just coming in and connecting that way, or if they can do it at home so that they don't have to put on a mask at all, that's also ideal. But I think there are going to be situations, right, where it's still, you still can't find your way around that.
Absolutely. Well, it looks like it's 10:30. I want to thank all of the participants for all of your questions and comments today. And thank you, Christina, for such an informative, practical, really great suggestions and ideas for assisting our vulnerable clients in the work that we're doing. Thank you for your work.
Thanks everyone for joining. I hope there was one or two things there, even if that's all you get out of it, right, that are just that help you in your practice as well. Thanks everyone.
Bye.
And thanks, Leslie.
Thank you.